Hello class. The next topic that we're going to talk about is a very important topic in regards to the respiratory system. We're going to talk about patients that require oxygen therapy, and then we're going to look at the specific patient who has a tracheostomy. And we'll talk about what indicates a patient to have a tracheostomy done, and really what is the nursing care that we need to provide to our patients with trachs to keep them safe and to definitely improve their respiratory status. So first of all, when we talk about oxygen, please note that oxygen is not a cure for the problem that our patients may have, okay? The goal of oxygen therapy is to use the lowest fraction of inspired O2 that will hopefully result in an acceptable blood O2 level without causing any harmful effects. Because remember, oxygen may be a good intervention for our patient, but with oxygen, depending on our patient's condition, it can pose some very serious threats and can cause some very serious complications. So that's why, as nurses, we need to constantly assess our patients when we're providing some type of oxygen delivery system, because changes can occur very quickly and we need to intervene very quickly to prevent our patient from deteriorating and causing such things as hypoxemia, which is low levels of oxygen in the blood, or hypoxia, which is decreased tissue oxygenation, okay? Remember, oxygen does improve the PaO2, but it doesn't cure the problem or stop the disease, okay? It may be a type of palliative treatment that kind of assists the patients to breathe more easily and maybe to get that PaO2 up just slightly, you know. We may not be doing ABGs on every patient we care for, but we definitely are assessing the respiratory status by the various methods that I talked about early in the assessment, you know, inspection, palpation, percussion, auscultation, and then of course by our pulse ox, you know, to determine how well our patients are oxygenating. You know, and then we have to look at the patient specifically, because for certain situations and for certain disease processes, you may think that oxygen may be a helpful therapy, but in reality, oxygen can actually harm the patient, especially when we talk about our patients with COPD who normally live in a hypoxic state, who normally live with high levels of CO2. And we have to realize how that respiratory effort works when we're talking about hypoxic drive. So these are the things that we need to consider. But I will say that with any situation, it's pretty safe to say that the one safest oxygen modality is our nasal cannula or O2 specs. I mean, it's pretty safe to say if our patients are experiencing any kind of issue related to a respiratory condition or a cardiac condition, we can put on oxygen per nasal cannula at about 2 liters flow. And even with a patient that we don't know much about their history, that may have COPD that we're not aware of, you know, we can pretty much say that that's pretty much of a safe flow of oxygen, but you know, it's still is necessary that we continue to observe and assess that patient to make sure that there still are no ill effects from that particular type of oxygen that we've been providing for a patient. And as I said before, the goal of oxygen therapy is to use the lowest fraction of inspired oxygen for an acceptable blood oxygen level without causing our patient to have any difficulties or very serious side effects. Now, we as nurses are very well rounded. We know so much about everything, but we do have to take advantage of our respiratory therapists, and they are the experts when it comes to the different types of oxygen that we're going to talk about in a few minutes. And when we're not sure of setups and maybe have a question about, is this the appropriate type of oxygen to use for this particular patient, It might be nice to kind of collaborate with the respiratory therapist along with the healthcare provider to determine if the patient is getting the best treatment and intervention for their particular problem. So don't be afraid to call respiratory. I've called them many times because they really do have the expert knowledge in all the different types of oxygen that we use on our patients and the different types of either high flow or low flow therapies, and they really can give you that information that you so need to keep your patients safe and obviously to oxygenate them the best possible way to prevent any complications from occurring. Okay. And I think always the question with the nurses is, what is the best type of oxygen for this particular patient? And, that is determined by, those continuous respiratory assessments that we make on our patients. Are they hypoxic? What kind of difficulties are we seeing? And that's why we look at things like, just our patient's color, and we look at their respiratory effort and how many times a minute they're breathing, and, are they in any distress, and what is the level of dyspnea that I'm seeing, and, what kind of breath sounds am I hearing, and has that changed over the last hour or so? And again, we use some of the diagnostic studies, and one thing that I hope you're practicing is your arterial blood gas studies. You've got to understand what those numbers mean and how do you interpret that, because you'll see that correlation. For instance, if you've got a patient with COPD or chronic obstructive pulmonary disease, are you seeing that patient with a higher level of CO2? That may be normal for that patient, especially if they're in the advanced stage of their disease process. And that's why it's so important that we know as much about the patient as possible, especially about their history, which to me, that's a fairly significant issue, because you would expect that, especially if somebody's had COPD for quite a while. You would expect that retention of CO2. But you wouldn't expect it on somebody that does not have a history of COPD. Maybe they were sedated too heavily. Maybe they had too much morphine, and their respiratory effort has really gotten decreased. You're seeing shallow breathing with this patient. So what is happening is they've been sedated so heavily that they're really not able to exhale that CO2, and that person is retaining CO2, which is a whole different pathology related to the patient who retains CO2 that has COPD. So these are the kind of things that we have to differentiate between, and I'm telling you, nurses need to know this. It's not an easy profession, but I'm trying to provide you the tools that you can best assess your patients and then make that evaluation and then provide a plan of care that better suits that particular person, depending on their history, what their present illness is, what brought them into the hospital, okay? But, it goes back to the old cliche that we're constantly assessing our patients using that all-important nursing process to determine, are these intervention promoting better patient outcomes for my patient, whether or not he has a respiratory problem or any other problem. Again, this slide just kind of denotes that oxygen intake and oxygen delivery, where are we meeting the needs of the patient? Are the tissue oxygen needs being met by providing proper levels of oxygen, as well as in touch or in collaboration with the cardiac system and the hematology system in regards to red blood cells? Do we have that balance, or do we see really quite an imbalance where we're tipping the scales? And, when we provide maybe some type of oxygen therapy, it really does help the heart, because providing that oxygen may help reduce the workload of the heart. And sometimes the compensatory mechanisms that we see because a patient may be hypoxic might be that, the heart rate is increased, or, patients may need some kind of intervention to increase the number of red blood cells, because maybe you're assessing on their CBC and diff that their hemoglobin hematocrits might be low. And that's a whole nother subject, but still that will affect how well our patients are being oxygenated. All right. So I just want to kind of run through some of the complications that we may see with oxygen therapy. And, you know, even as long as I've been a nurse, there's a few of them that I have seen and others that I really have not really witnessed as much. But I want you to be aware that these potential hazards and complications can occur anytime we're, you know, using or implementing oxygen therapy with our patients, okay? And, you know, the first one is combustion, okay? And, you know, the old cliche was that, you know, be careful around, you know, open fires because especially if our patients are on oxygen and somebody around them, you know, is smoking, things can catch on fire. Well, that's kind of partly true, but really, as the slide says, O2 itself does not burn, okay, but it does support and enhance combustion, at least when your patient's on 50% FiO2. And so I think the whole principle behind this particular hazard is we just have to implement safety when our patients do have oxygen. And this also needs to be taught to our patients when they go home. Having safe electrical equipment, grounded, no arcing or sparks, frayed cords, keeping lighted candles away from people, alcohol or oil solutions that could also cause combustion to happen. So these are things that we need to practice, obviously, in the clinical setting, but then, again, relate this information to our patients and their families, especially if we've got people going home on oxygen. The next one is probably a more common type of hazard that I kind of touched on just a few minutes ago, oxygen-induced hypoventilation. And we're talking about the population of patients who need that hypoxia to exist, which gives them that drive to breathe, okay? For instance, the population of people who have COPD, they definitely live at a very low oxygen level as the progression of that disease occurs, and they live with low PaO2s and they live with high PCO2s, but the body learns to adapt with that. That's just the condition they live in, and that's with people who have had COPD for a long period of time, because it is a progressive disease, which we'll talk about later on in some of the upcoming chapters. But for now, trust me when I say that is basically what kind of blood gases we see on those patients. Well, if we go ahead and think, oh, wow, they're living in a very hypoxic state, why don't I just increase their oxygen concentration, maybe from 2 liters to 5 liters? What that does is that will definitely increase their PaO2, but then it also affects that hypoxic drive, because that is what keeps them breathing. That's that neuro intervention that causes us to breathe. And that same principle kind of is seen with our patients who have maybe sleep apnea at night, and we'll get into that when we discuss kind of CPAP versus BiPAP. People that have sleep apnea, and that's people that go to bed at night and have periods where they quit breathing. And what happens is when they quit breathing, obviously their PaO2s go down, and then something kind of stimulates because they have a normal healthy brain, and because the oxygen levels start decreasing, something tells them and forces them to wake up and start breathing again to bring that FiO2 levels up again. So this is how our bodies work in collaboration with our brains and the neural communication that we have to cause us to breathe, and that's just how it works. If you go back and look at your anatomy and physiology, this is why we breathe. We breathe effortlessly when we have no brain injury. It just happens. We don't even have to think about it. So this is what oxygen-induced hypoventilation is. And that hypoxic state is that drive to breathe, and that's why we put our patients with COPD on the lowest liter flow. And we might see O2 prescribed at 1, 2, 3 liters. And that's why, you know, when we come on as nurses and we're assigned our patient assignment, you know, and you get and report that your patient's on oxygen, it's very important to make sure that's what the last order was. And that's one of our first assessments we do when we first come on and take care of these patients, is to make sure that if they're supposed to be at 2 or 3 liters, that's what they should be at, okay? And so if you see some discrepancy in that and the patient's on a higher or lower, it's always always good to go back and look at those orders to make sure that we are providing exactly what the physician has ordered. And then maybe with our COPDers, if we see a higher than normal type of liter flow, we might want to question that. Why is my COPD patient on 4 or 5 liters? Because there might be a very good reason why. But the important thing is that we're delivering exactly what is, you know, been ordered. And then if there's something that just doesn't seem right because of our knowledge of why that particular patient should not have a high liter flow of oxygen, then it's okay to question it to make sure. Because the bottom line is we have to keep these patients safe when they are on some type of oxygen, okay? And we're going to talk about the more precise oxygen levels, such as, you know, a Venturi mask, you know, and things like that, because that's more of a high flow oxygen, and we'll get into that in just a few minutes. But I hope that makes sense when I talk about oxygen-induced hypoventilation. You know, it's those COPDers that live in a state of high CO2 called hypercarbia, and a low state of oxygen levels in a state of hypoxia. And usually when we start, you know, intervening with certain types of oxygen, really, especially if we're changing that particular type of therapy, stay with your patient or check them frequently, because if we're going to see some negative changes, where they may start to deteriorate and not really get better from the change in the oxygen therapy, it's probably going to happen in the first 30 minutes. So it's important that you assess that and make sure that the patient is safe and that they're breathing okay. Because sometimes those changes can cause your patient to kind of deteriorate and go bad and become more hypoxic. And that's why we, you know, assess their respiratory pattern, we look at their rate, we look at their color, and we just look at the, you know, that symmetry. Are they breathing okay? Are they, you know, is it effortless breath, or are they using all their accessory muscles? And remember, too, we have to relate their level of consciousness with their breathing effort, because if they're not getting in proper amounts of oxygen, we're going to see changes that affect their level of consciousness and also their cardiac status, because if the heart is not receiving enough oxygen, this is when we can see rate changes. Patients can start to have irregular heartbeats, and if they have a history of heart disease, we might see the patient also develop what we call angina, which is, you know, atherosclerosis, you know, things like that. So you see how one system, when it's not working well, can affect another system. So really think about, you know, level of consciousness. And even a patient who begins to become restless, it's always important to say, why is that patient all of a sudden restless? Because think about it, when you're not taking in a proper amount of oxygen, it does affect the neural function and the level of consciousness. So sometimes it's because hypoxia is setting in, and that may be the reason why your patient may be a little bit more restless, because they're not breathing well, and that is something that you must consider. And that's a good time to maybe, you know, obviously assess vital signs, pulse ox, and maybe do some ABGs on these patients, because there's probably going to be some pathology related to why your patient is behaving that way. So the next thing that we want to talk about is O2 toxicity. And I guess we don't really think about this, but this is for patients who are on 50% oxygen concentration for more than 24 hours. Because you think oxygen is going to help, but it can actually damage the lung because it is at such a high percentage. And that's why when we get report and we know what kind of oxygen our patients are on, it's really important that we kind of ask the nurse, okay, when did he start on this high level of oxygen? Because then you can kind of start thinking in yourself, okay, if he started on this a day ago, and he's still on 50%, and he's still not really bringing up that PaO2, I might want to look for signs of toxicity, okay? And, those initial symptoms that happen are, non-productive cough. And that's one thing you really want to be aware of. Because if your patient hasn't been coughing and all of a sudden they've been on a 50% percentage of oxygen, and then all of a sudden now you notice that they're just kind of giving you that subtle non-productive cough, it may be a sign that it's causing irritation and damage to the lung tissue, and that's why the patient begins to cough. Along with that, substernal chest pain, and then if this is not kind of assessed and it continues to kind of snowball, you're going to see patients start to have, GI upset and increased dyspnea, and it really presents a lot of the same manifestations as somebody who has adult respiratory distress syndrome, which we'll learn about when we get to critical care or nursing 213. And prolonged exposure to high oxygen levels will damage lung tissues, and that's where you'll start to see some really advanced problems like atelectasis, even pulmonary edema, and they can even have hemorrhage. And you'll see decreased vital capacity, decreased lung compliance, increasing dyspnea, and you might even hear a lot of crackles. So maybe prior to that, the patient was, had pretty much clear breath sounds, and all of a sudden they're developing crackles. You may want to definitely assess that, hey, is the reason for this happening is because the patient has been on high concentrations of oxygen for too long and it's causing damage to the lung tissues. This is where a lot of times instead of increasing the oxygen level, we may put patients on a CPAP, a continuous positive airway pressure with an O2 mask, or maybe a bi-level positive airway pressure called BiPAP. And when they're on a mechanical ventilator, that's very much comparable to what we call as PEEP, which is positive end expiratory pressure on a mechanical ventilation or a respirator, as you might know it. And that's why, we want to provide the lowest possible oxygen needed to maintain oxygenation, and that's why we, of course, watch our patients and then, really draw blood gases to get those precise numbers as to what's really happening with our patient. So, think about that. That might be an alternative therapy or intervention, is to put the patient on CPAP rather than keep increasing their oxygen percentage. And then we don't have to worry about oxygen toxicity as much. Okay, so the next one is absorption atelectasis, and this is where think about nitrogen versus oxygen. Nitrogen makes up about 79% of room air, and the other is oxygen, which makes up about 21%. And it's the nitrogen that actually prevents alveolar collapse, and high levels of oxygen are given, it starts to dilute that nitrogen, and then O2 diffuses from the alveoli into circulation, and then you might have alveolar collapse. So that's why we just listen for breath sounds every couple hours and monitor for crackles, and this can be detected by auscultation, and this is why it's so important to always keep up on your patient's breath sounds. So that's why we need to monitor these patients for the first couple hours when oxygen therapy is started on our patients. And then, of course, the next one is drying of mucous membranes. When you've got a patient on a higher liter flow, say 4 liters, we might want to add a little humidity because that oxygen can be very drying and cause the mucous membranes to kind of dry out. You might have some irritation and bleeding. So we might put on a humidifier, and you don't need an order for that. Usually they're on the unit. Just make sure you set it up correctly. You might ask respiratory to do that. What I like to do is date those bottles because they're disposable. They're just in plastic bottles, and what's in there is sterile water. And you need to know what the policy of the hospital is, because sometimes those some hospitals require those to be changed every 24 or even 48 hours, and if they're not, your patients can definitely acquire some type of respiratory infection, because that water can brew bacteria and organisms, and one of the main types of organism is Pseudomonas. So remember that. So be aware of the policy in your hospital, and respiratory therapy will help you with that. So you might want to change those humidifier bottles every 24 hours, okay? So that's pretty much the hazards and complications of oxygen therapy. And here's a picture of what that might look like, but these don't look like they're disposable, but this is what a humidifier bottle would look like, but it's more in a plastic container. And the important thing is you'll hear bubbling, and that's a sign that you know, that patient is getting that humidity. So I just kind of wanted to show you that, but this is a very obsolete picture. It's, you know, from way back 2006, 2002, and that's not the type of equipment we use nowadays, okay? Okay, now we're going to talk about oxygen delivery systems. Low flow versus high flow. So the question I have for you is, as you think about these types of oxygen delivery systems, what's the difference? And that's a great question. So what do we mean by low flow? What do we mean by high flow? What we mean by these two different types of delivery systems is low flow are certain therapies that we provide our patients, and whether or not our patient is getting that particular oxygen concentration is very dependent on what their respiratory status is, okay? So what do I mean by that? So for instance, if you have a patient who is going to be ordered nasal cannula, which you see in the picture here on the left, we know the flow rate can be anywhere from 1 to 6 liters per minute. And the highest amount of oxygen that we can deliver with a nasal cannula is 44%, and that would be at 6 liters, okay? All right, so the patient, you know, has no history of COPD, and we put this patient on a nasal cannula at 6 liters. Are they going to get that 44%? We're not quite sure, because it really is very dependent on your patient's own respiratory effort, how well they're breathing. So maybe, you know, their respiratory rate is, you know, increased, and they're not really breathing as well as we'd like them to be. Maybe it's more of a shallow breathing. They may not be getting that 44% because it's very dependent on what their respiratory effort is. Where with high flow, if we say, hey, I want to deliver, all right, 50% per Venturi mask, we will give 50%, and it's not dependent on the type of respiratory effort our patients demonstrate. So that's kind of the difference. These low flows provide a certain percentage of oxygen, but we're not always sure our patients are getting that. That's why we have to do those constant assessments, maybe, you know, draw blood gases on our patients and determine if, you know, that's the best choice for the patients because of their own, you know, specific respiratory effort that they're displaying. So I don't want you to memorize, if the patient's on 2 liters, how much percentage of oxygen, because memorization is very surface learning. You're going to forget it. I just want you to be aware of the difference between low and high flow, and these are the various types of delivery systems with low flow. And obviously the most common one is nasal cannula, and we use this a lot with our COPD patients, okay? And even patients who have long-term respiratory problems, maybe even cardiac problems, patients that have, pulmonary fibrosis, people that really have a pathology related to how much oxygen they're getting. But like I said, it's not effective over 6 liters, and the reason COPDers like nasal cannulas is because they're not really crazy about masks because they feel very claustrophobic. And obviously, again, reminding you that with our COPDers, they do retain CO2, so we never want to put it any higher than 2 or 3 liters because we don't want them to lose their hypoxic drive. But believe me, there can be exceptions to the rule, and that is dependent on the patient itself and what the physician orders for the patient. But remember, the higher the flow rate, it can cause that mucosal irritation, and so that's why sometimes we want to determine if humidity is needed. So remember that, humidity for flow rates 4 liters or above, okay? So that's nasal cannula, and I think just the important thing is, like with anything, when we're putting a device on a patient's face, be careful of how tight we make it, because some of these patients have really poor skin integrity, and we don't want to see breakdown, okay? So, and we want to make sure that they're put on correctly with the prongs and so and so. So if the patient's ordered 2 liters of oxygen, let's make sure it's on the patient, it's not laying in the bed, and make sure that the flow rate is at that designated level. Many times our patients leave the units because of some, they go down for a chest x-ray, they come back, they've got their nasal cannula on, but nobody turned back on the flow of oxygen. So those are the things that we need to really be very conscious of to make sure the patients are getting delivered what has been ordered. Simple face mask, it's for short-term oxygen therapy. The minimum amount of flow rate is 5 liters per minute, and that's to prevent our patients from rebreathing that exhaled air. You want to make sure it fits securely. A lot of times when they're on the simple face mask, because it can provide a higher concentration of oxygen, about 40 to 60%. Many times if your patients are on a simple face mask while they're eating, obviously they can't eat when they've got the face mask on, you can switch them over to a nasal cannula so they can be more comfortable and eat. But usually we see the flow rate at about 5 to 8 liters per minute. And as I can't stress the importance of making sure that it's on properly, it's not too tight, and really to assess the skin integrity on the face, behind the ears, around the nose, because sometimes those prongs can be very irritating with the nasal cannula, that they irritate those the nares and the mucosa inside there. So that's that. And then the next one is a partial rebreather. And as we advance up with these different types of masks, you're going to start providing a higher concentration of oxygen. The one on the left is the partial rebreather, and as you notice, you'll see it's a reservoir bag, but there are no flaps. And this bag needs to be slightly inflated at the end of inspiration to make sure the patient is getting the prescribed amount of oxygen. And again, we can provide up to 60 to 75% of oxygen percentage. And with that, we have to make sure that the liter flow is at approximately 6 to 11 liters per minute. And then the last one is a non-rebreather, and this is the highest O2 level with our low flow system, okay? And we're getting into a very high oxygen percentage, 80 to 95%. To maintain, and that reservoir bag needs to be about 2/3 full. It provides the highest O2 level of the low flow systems and can deliver an FiO2 of at least 90%, depending on how the patient is breathing. Again, we don't always know if it's being delivered that way. This is where you would find a patient with a non-rebreather mask on who's becoming very unstable. Maybe at this point it might be necessary to intubate the patient, and that means to put an endotube down the trachea so that we can mechanically ventilate them, either manually with an ambu bag or put them on a ventilator. There is a one-way valve between the mask and the reservoir, and there are 2 flaps over the inhalation ports. And the bag must be inflated during inhalation to about 10, and we can do that with about 10 to 15 liters per minute. So that's your low flow type of oxygen. And then your high flow, probably one of the most popular ones is your Venturi mask. That delivers the most accurate O2 concentration, can also be known as a Venti mask. And I'll show you in a minute on the next slide the little, there's little rings that are color-coded that give you as to how much percentage of oxygen the patient is being delivered. And then your face tent is a tent that fits over the chin. The top goes halfway across the face, and this might be somebody who has had some kind of facial trauma, maybe a burn victim. Obviously you can't put a mask on their face, but that would be the type of oxygen therapy we would give to that patient. Aerosol mask, high humidity after intubation, maybe somebody that has a lot of thick secretions. And then we'll talk about tracheostomy collar in just a few minutes. And then the T-piece, and that can be put on the patient maybe after they've been taken off the ventilator to make sure they're tolerating being off the ventilator, and we'll connect humidity and oxygen to that T-piece, and I'll show you a picture in a minute of that. And then they'll check blood gases, maybe check the patient's tidal volume, and if the patient still remains stable, that they're breathing well on their own, then they can remove the endotube. This is a Venturi mask, and right here you'll see the little removal adapter type color-coded things that you look on that, and like maybe the orange will say 50%, the red one maybe 40%. So when you get report and they say the patient's on a 50% Venturi mask, you'll look at that little removable adapter, because they're all color-coded, and it will show right on here how much oxygen the patient's being delivered, and we want to make sure that's the correct amount. Now this is high flow Venturi mask, so when we say we're giving 50%, it does not depend on the patient's respiratory status or their respiratory effort. They're going to get 50% delivered. And then this is that T-piece I was talking about. The bottom portion is the endo tube, which will be in the patient's trachea, and let me show you that. I'm trying to bring this picture down so you can visualize that better. But this is the endo tube, and we connect this T-piece to that, and it has oxygen, and you'll see humidity, and you'll see it kind of coming out of these side ports. And this is the endo tube that's in your patient still, and they are just being sure that the patient is tolerating being off the ventilator. And then once the blood gases come back that show that the patient is oxygenating properly, then we can extubate or take out that tube. Okay, so that's a T-piece. All right, and then we're going to talk a minute on BiPAP and CPAP. Okay, let's go over these two types of therapies, BiPAP and CPAP. Okay, these are techniques that uses positive pressure to keep the alveoli open and improve gas exchange without airway intubation. And just think about it. If you're keeping those airways open, we have a better exchange of gases and better oxygenation. Because remember, that's where the diffusion of gases takes place in that alveoli. Okay. So first of all, BiPAP is that mechanical delivery of set positive inspiratory pressures each time the patient begins to inspire. And what it is basically is two pressures. You have IPAP, which is the inspiratory airway pressure, and EPAP, which is the expiratory pressure. And this does help increase ventilation. It helps to remove CO2. And you might be used to see that BiPAP might be used for somebody that has maybe atelectasis with a lot of increased CO2 retention. Maybe somebody that can't be intubated, maybe somebody that has, heart failure. One thing with, your BiPAP is that it exerts high pressure when the patient breathes in and delivers low pressure when the patient breathes out, okay? And BiPAP reduces the pressure when exhaled and increases pressure when inhaled. And you can't adjust this when you have somebody that has CPAP, okay? We use this, like I said, certain lung diseases, heart failure, COPD. This is probably the more complex therapy, or more expensive type therapy, because CPAP is obviously cheaper, okay? But some of our patients do need those two types of non-invasive pressures, where your inspiratory effort is more of a high pressure and your expiratory effort is more of a low pressure, okay? So just wanted to kind of, differentiate between the two. And then, CPAP is, again, one pressure, kind of the same as PEEP that we have on our ventilators. It helps to decrease a lot of preload and helps decrease the workload of the heart. It can also, applies that continuous pressure to the airways. And with CPAP, another important differentiation between that and BiPAP is the person has to use more force for exhaling against the extra pressure. So it can be very tiresome for some people, especially those having maybe like neuromuscular diseases. But we do see CPAP used most often for problems like sleep apnea and, CPAP, usually the equipment is a little bit larger than the BiPAP, okay? So So that's kind of the difference, and that's pretty much all you need to know, okay, when we're talking about the two types of non-invasive positive pressures that are possibly ordered for your patient. And this is kind of what CPAP looks like. Some of the devices are a lot more compact, and it's important too that some of the companies that provide this equipment will teach the patient when they go home on these therapies how to clean the equipment, because you don't want organisms and pathogens to kind of harbor in the tubing that you're inhaling those, because they can really present the patient with pulmonary infections and things like that. Okay. Another thing is tracheal oxygen delivery used for long-term delivery of oxygen directly into the lungs. It kind of bypasses those irritation of the nasal prongs and can be a little bit more comfortable. You might see different flow rates prescribed for the patient depending on, when they're at rest and when they're being a little bit more active. I personally have never seen this type of oxygen therapy, but it is a possibility with some of our patients, okay, especially when they need oxygen for long-term use. Again, thinking about home oxygen therapy, the criteria for home oxygen therapy equipment, a lot of teaching needs to go into this when our patients are sent home on oxygen. Many times, in order for this to be paid for, the patient or the person must have severe hypoxia, usually below 55%, or the pulse ox is below 88% when they're on room air or at rest. And a lot of times we'll assess that with activity and provide that information to like Medicare or Medicaid, so these are pretty much paid for the patient. But again, good teaching, safety, talking about no smoking, as we talked about, that combustion hazard. Those are things that we just need to talk about with both family and with the patient. Okay. And the good thing about oxygen therapy now is many of the devices are much easier for patient to, carry across their shoulders, so people can go out in public and, kind of be involved in family functions and activities of normal daily living, so they're not kind of straddled down with a real cumbersome oxygen tank. As you can see the picture on the left, where the person is walking down the hall with their oxygen tank, it's really important that we store oxygen safely in the hospital. It should never be leaned up against the wall. We don't want those tanks falling and hitting the ground. They can cause combustion and problems like that. So, safety must be implemented in the hospital, as well as teaching our patients to implement that safety when they go home. All right. The last thing I'm going to talk a few minutes about is tracheostomies, okay? And this slide just tells you the difference between tracheostomies versus tracheotomies. Tracheotomy is that surgical incision into the trachea for the purpose of establishing an airway, and tracheostomy is the stoma or opening that results from the procedure of the tracheotomy. Remember, this procedure can be done either temporarily or permanent. And if you're taking care of a patient who does have a tracheotomy, it's always good to kind of get a little bit of their history. Why does my patient have a trach? I want to kind of know what happened that kind of warranted this. If it's temporary, that's a good thing. But still, we need to do proper teaching and, implement conditions that keep our patients safe and that, do not obstruct that airway. Because now, thinking about it, this is a whole new way of breathing, and this is our patient's lifeline through that tracheostomy to keep them properly oxygenated. But with that, we can see situations develop, especially when we talk about suctioning and things like that. So we'll get into some of the complications that we may see with this. All right, so this is just a picture showing you maybe where some of the cardiovascular surgeons would make that incision. And you can see more of a up and down incision, kind of near the second, third, and fourth tracheal rings. Now, It would be ideal if our patients were scheduled to have a tracheotomy, that we could do preoperative care and preoperative teaching, but sometimes tracheostomies are done under emergency type of conditions, there obviously is no time to kind of teach the patients about what to expect. So a lot of times when the procedure's finished or completed, then we have to do the teaching and let them know about certain things that we must do in order to keep a patent airway and prevent our patients from some of the complications that we might see, whether it's bleeding, infection, aspiration, or whatever the case may be. These are some of the possible complications, tube obstruction, tube dislodgement, and accidental decannulation, meaning that if the patient would cough forcefully, they might be able to forcefully expel the tracheostomy tubing, or the tube. That doesn't happen very often because when these are done, the physician does suture them in, so you might be able to expel the inner cannula if it's not put in properly. But sometimes if they're not sutured in, that's when we might see accidental decannulation. Immediately after the procedure, there's certain things that can happen. Think about where the physician made that incision. Very close to the apex of the lungs, so there's always a possibility of a pneumothorax, subcutaneous emphysema where you feel that snap, crackle, pop, or bleeding. We might get a little bit of pink drainage in the first few days, but that's normal. And remember, this is a surgical procedure and should be done under sterile aseptic conditions. And so if not, our patients are also at risk for infection. Now these are the type of tracheostomy tubings, disposable or reusable, cuff tubes or tubes without a cuff for airway maintenance, inner cannula, disposable, reusable, or a fenestrated tube. I'm going to go over this, but I think sometimes tracheostomies and the equipment that goes along with it really makes a lot more sense when you have had experience taking care of a patient with a tracheotomy. There's new policies that have been implemented with tracheostomy care. I think I'll just kind of give you a general type of suggestions on how to care for these, but we've come a long way as far as tracheostomies. We used to use metal trachs. They don't even use those anymore. They definitely have the shyly disposable trachs, which is a good thing. But I'll kind of show you some pictures of some of the equipment that goes with tracheostomy tubes. And this is one. As you can see, hopefully that's in your screen. Here, let me bring that slide back. There we go. Hopefully I brought that in. Probably the most common one is this one on the right, the middle one, the white one. This is a typical Shiley trach, and this is where the sutures would be kind of tied into this to the patient's skin, along with the trach ties, which goes around the patient's necks. This is what we call a cuff, and as you can see, it's connected to a little tubing, which we inject air in this, and this kind of blows up kind of like a balloon, and this kind of makes a seal, so we get a good, it can provide the patient a good oxygenation. And this is what we call an obturator. And what we do with this is, the one on the right, is after a patient has a trach, we tape this up to the wall so that if this would come out, we can always insert this into the patient's stoma. Because a lot of times in the beginning, when the patient first has the surgery, if the trach would come out, it would close up, and that would not be a good thing, because that is your patient's airway, and that would be a huge problem and cause an obstruction and could get your patients into a lot of respiratory problems. This is the cuff that's inflated. This is what we call the outer cannula. And then right over here on the left, these are like the inner cannula that goes into here. This kind of turns, these come out, and then we clean them. And a lot of times now they're actually disposing them, and then disposing of them, and then they'll bring in a clean, absolutely new cannula. Okay, we'll talk a little bit about this cuff pressure. because a lot of times respiratory will come up and measure this because we don't want too much pressure in this, causing pressure on the tracheal tissues, but we do want enough that warrants this to be at a proper level of pressure, so we do get a good seal. And this is what we call a fenestrated. This is maybe a type of trach that we might put in a patient who's being weaned, okay, because you can see now that they don't need a complete seal because you've got these holes in the back of the tracheostomy tubing, okay. That still should fit very precisely and lie centrally in the airway. Otherwise, you might see granulation tissue will grow within the fenestration, having to have surgery to remove it. So it's very important that it's in the right and proper position. And it's also important too that when your patient has a tracheostomy, that you have another one of the same size. They do come in size. 7 Shiley trach is probably one of the most common sizes. So if that's what your patient has, you would have another 7 size Shiley there at the bedside in case something would be wrong with this. We would have it right there available, so the physician could definitely insert another one. Some of the complications that we see are, tracheal stenosis, which can be caused by scar tissue, sometimes tracheoesophageal fistulas. And another thing that's a very serious, and it's a medical emergency, is the rupture of the innominate artery. And obviously that would be massive bleeding and would call for a medical emergency, okay? Other complications could be bleeding, pneumothorax, air embolus, aspiration, and even laryngeal nerve damage. And we'll show you that some of the things that are imperative that we provide when our patients have trachs are humidity, watching that cough pressure, and I'll talk about the proper way to suction, and really maintaining good skin integrity, and continuously assessing breath sounds, looking for signs of infection, providing hydration, humidity, and oxygen, and always when suctioning, anytime around the trach, that it is a sterile procedure and a sterile technique. And this is again that prevention of tissue damage that I just talked about. And think about it too. You've got to understand now that a patient has a trach, they're not going to be able to speak, they're not going to be able to eat, and so life has changed drastically for these patients, okay? And we have to prevent and treat that malnutrition and keep them hemodynamically stable and prevent problems with hypoxia. And this is the cuff pressure that they hook up to that little end of the cuff to determine if it has enough pressure in it, to make sure that we have an adequate seal but not too much pressure that it causes pressure on the very delicate tissues in the trachea, causing that tissue to become ischemic. And the tracheostomy tube bypasses the nose and mouth, which normally humidify, warm, and filter the air, so that air must be humidified. So that's why we give our patients maybe like a cuff on there over the tracheostomy to provide that humidity at a proper temperature and to ensure that the patient receives adequate hydration. All right, let's talk about suctioning, because this is huge. Many times if our patients are unable to bring up their own secretions, we need to manually go in there and suction our patient to keep that airway open and to promote proper gas exchange. And suctioning can be done through the nose or the mouth, but for the most part, if our patients aren't able to cough up their own secretions, we can actually go down the tracheostomy. Okay, think about it. We're not only suctioning out secretions to keep an open airway, we're also suctioning out oxygen. So with that said, is we can cause hypoxia, tissue mucosal trauma, infection, vasostimulation, which can initiate a bronchospasm, or even cardiac dysrhythmia from the hypoxia caused by improper suctioning and improper oxygenation. So what do? the best thing to do when patients are going to be suctioned is you need to have an ambu bag that's connected to the tubing, to the flow meter, and we put it at 100%. And what we do is we let the patient know that we're going to use that ambu bag and give them 2 or 3 breaths of 100% concentration of oxygen. So we pre-oxygenate the patient before the actual suctioning. Now, the hospitals have what we call tracheostomy kits. They have catheters that are made to be very soft and flexible to prevent damage to the mucosa tissue. So we get that out, and this is a sterile procedure. It should be done with sterile gloves, and we don't want to prolong suctioning or use excessive suctioning or too much suctioning, okay? Because like I said, when you suction secretions out, you suction your patient's oxygen. So these are things that can happen, and what you do is as you advance that catheter down, if your patient is alert and oriented, you need to tell them that you're going to suction them, because this is very traumatic. Think about something going down your trachea. It's going to stimulate the cough reflex. You'll see your patient, sometimes cough very drastically, but it would make sense because your patient is having some foreign catheter material going down in the tracheostomy, and that's just nature's way of dealing with it. They cough. But so you want to go down there, and you only hold your thumb on the suction as you come out, and get out very quickly. And then after you suction, you use that ambu bag, and you give your patient 2 or 3 breaths to re-oxygenate them with that 100% oxygen to kind of restore what you just suctioned out. Sometimes if it's not done under sterile conditions, you can cause an infection, and sometimes we've seen that in our patients, because many times you'll know when it's an infection because the secretions may be very foul smelling. They might be green or brown in color, which could denote that the patient is suffering from a respiratory infection, maybe caused by the organism Pseudomonas. But also vasostimulation could cause the patient to have changes in their cardiac rhythm, can initiate a bronchospasm. So many times if that happens, we might have respiratory come up and give like a respiratory treatment with albuterol to open up those airways and kind of override that bronchospasm that may be occurring. And then again, sometimes, you want to make sure that if you're changing the trach ties, that you maybe have another person there to secure that tracheostomy too, especially if it's not sutured in, because if a patient gives a good cough, that thing could go flying out. Now you have, and especially if it's a fresh trach, that stoma is going to close up. Bronchial and oral hygiene. Turn and reposition the patient every 1 to 2 hours. Get them out of bed. Teach them about coughing and deep breathing. If they can cough up these secretions on their own, that's great. Then we don't have to interfere with the actual suctioning. Oral hygiene, remember, they're not going to be taking in a lot of food and fluids, so proper mouth care, but avoid those glycerin swabs, anything that contains alcohol, and look at their mouth inside to make sure they don't have any ulcers, bacterial or fungal growth, or infections. Giving them good mouth care. Nutrition, swallowing may be a major problem for the patient with a trach. If the balloon is inflated, it can interfere with the passage of food through the esophagus. If they're able to eat, you elevate the head of the bed for at least 30 minutes after the patient eats to prevent aspiration. Think about speech and communication. They can speak if it doesn't have a cuff, they can speak if it's a cuffless tube fenestrated or even cuff fenestrated that is capped or covered. Make sure to prevent over frustration of the patient, that you ask them very simply yes or no questions. Sometimes it's nice to get a little whiteboard in their room that they can write little messages, because without proper communication, you can see your patient get very, very frustrated. Patients may need to be weaned, and that can happen gradually. Maybe they decrease the tube size, and then ultimately remove it if it's a temporary trach. Cuff is deflated as soon as the patient can manage secretions and does not need assisted ventilation. And that's basically all with tracheostomy. So make sure you read that over in your book, and if you have any questions, please let me know.